Okay, good morning, everyone. So, as usual, we are starting next lecture, and this is a very important topic. When you will in palliative care setting, many times you will find people with malignant biliary obstruction, and sometimes they straight away come to registered in palliative medicine, and we should have a idea that what is the systematic approach to uh, address this problem or approach these patients. So for this, we have a TMH Mumbai team, and I request Dr. Joyita to introduce the speaker and moderator, Dr. Raghu and Dr. Varun. Dr. Joyita, please go ahead.
Good morning, ma'am, and good morning, friends. Thank you for having us again on this Monday for doing this topic. So to present, we have Dr. Varun, who is in his second year of MD Palliative Medicine at our department in Tata Memorial Hospital. He just recently presented a poster at IAPCon 2023, which is on symptom profile and management of advanced cancer patients at the end of life care in our hospital setting. The reason he did it because his real interest lies in end of life care. He's also interested in management of pain crisis and palliative care in the oncological emergency settings. Outside of his interest in all these areas in palliative medicine, Varun is a really good chess player as well as plays TT and badminton. And he has recently taken part in our hospital-wide games competition that we have. And for all the palliative medicine residents on the group, most of you would have met Varun in Bangalore, and all of you would agree that he is one of the most friendliest persons you will ever meet. So Dr. Varun will be speaking on this particular topic, and to moderate is our Dr. Raghu Thota, who is our professor in Department of Palliative Medicine. He spent many years in anesthesia and pain, and since 2 years, he has been with us in the department. He is currently enrolled in the Cardiff University Diploma in Palliative Medicine program. And if you see his email, there is a list of associations that he has founded and he is holding, which is the editorial board member of Pain Physician Journal. He is the founder president of SIP and is the founder secretary for the Society of Onco-Anesthesia and Peri-Op Care. And of course, he's our examiner both in anesthesia and now in palliative medicine, and also DM Onco-Anesthesia. He has been the pushing force behind the Indian Cancer Pain Management Guidelines, and his special interest areas are palliative medicine and point of care ultrasound, refractory cancer pain, end of life care and advanced care planning, cancer interventions, of course, because he's a very good interventionist in pain and palliative care. And his other interest, which he's working on, is ICU palliative care. And he has won many awards and he has many publications. So to moderate the session is Dr. Raghu. So I hand over to Dr. Varun and Dr. Raghu. Thank you.
Good morning, everyone. So today's topic has already been introduced by Sushma Madam, malignant biliary tree obstruction. As she already said that most of the patients do present earlier presentation with the malignant biliary tree obstruction itself, or rather, not that, but rather with jaundice or pruritus, where they come to our palliative care unit. And that's why this topic becomes very important that we really need to understand the basic pathophysiology, I can say the physiology of the bile, as well as the interventions or the procedures or the palliative approach, what we do to these patients. So it has been very beautifully drafted by Dr. Varun, and I hand over to him to take it forward. Over to you, Dr. Varun.
Thank you, sir.
Thank you, sir.
Is my screen visible now?
Yes, we can see your screen. Go ahead.
Good morning, everyone. Thanks for the introduction, ma'am. And today's topic is about the palliative care in malignant biliary tree obstruction. Today, in the next 40 to 45 minutes, we will be covering topics like what are the malignancies which cause the biliary tree obstruction, and what are the symptoms the patients face in these conditions, and what all can be done to alleviate these symptoms. Before starting all this, let's have a basic idea about the anatomy and all the malignancies which can cause the distortion in this anatomy. Here, the cancer may arise from the gallbladder or from the head of the pancreas, or it might be even in the small duodenum, common bile duct, or it might be due to the metastasis in the liver or a primary arising from the liver. All these cancers, they cause the blockage in the biliary common bile duct or the biliary tree, and they cause the cholestasis. Coming to the normal pathway of the biliary excretion, what are the unconjugated bilirubin that is formed in the body? It goes to the liver where it is conjugated, and then it is excreted. Into the small intestine, where it is acted upon by the colonic bacteria and forms the stercobilinogen, and it is eliminated in the stool in the form of stercobilin, and part of it is taken up by the blood, and it is transported back to the liver for the enterohepatic circulation, and a part of it is also transported to the kidney, and it is excreted from the urine as urobilin. Here we can see a table which enumerates the causes of the cholestatic jaundice. This cholestatic jaundice, it can be caused due to the intrahepatic causes and also to the extrahepatic causes. The common intrahepatic causes which causes the cholestatic jaundice, they are the primary biliary cholangitis, primary sclerosing cholangitis, or might be to the alcohol or to the drugs. It can be due to cystic fibrosis or other severe bacterial infections. And coming to the extrahepatic causes, carcinoma, they are the most common extrahepatic cause of cholestatic jaundice. The examples are the ampullary carcinoma or the pancreatic carcinoma, cholangiocarcinoma, or maybe due to the liver metastasis. Other extrahepatic causes, they include parasitic infection, traumatic biliary strictures, chronic pancreatitis, or the choledocholithiasis. Now coming to our main topic, that are the malignancies which are causing the obstructive jaundice, or the carcinoma gallbladder, cholangiocarcinoma, pancreatic adenocarcinoma, as mentioned earlier, metastasis to the liver, or it might be due to the lymph nodal compression of the common bile duct, or it might be also due to the duodenal carcinoma. Next, here we can see the incidence of jaundice in these malignancies. The highest is due to the CA pancreas, in which 75% of the patients, they will have the cholestatic jaundice. Next is due to the CA gallbladder, where we can see jaundice in 30 to 60% of the patients, followed by hepatocellular carcinoma, and then the cholangiocarcinoma. Here, if it is untreated, if the cholestatic obstructive jaundice is untreated, it leads to the progressive liver dysfunction, and then causing to the liver failure and also early death. This obstruction, it needs to be drained even in such cases, because it helps in the alleviation of the pain, cholangitis, pruritus, or in certain cases to initiate the chemo or the intrabiliary brachytherapy. And it also helps in the decrease in the other symptoms like anorexia, nausea. And what are the methods we have to decrease this obstruction, to decrease this obstructive jaundice? Coming to the methods of biliary drainage. Mainly, there are two methods of the biliary drainage. First is the surgical bypass, which is a very complex procedure. And next are the minimally invasive procedures, that are the ERCP, that is endoscopic retrograde cholangiopancreaticography, And next is the PTBD, that is percutaneous transhepatic biliary drainage. And choosing all these options, whatever the surgical options or the endoscopic options we have, depends on the performance status of the patient. So here I have put forward a flow chart. Here we can see if the performance status of the patient is very poor, then neither of these procedures, cholestatic jaundice draining procedures, can be offered for the patient. So directly the patient will be declared as the best supportive care. And if the performance status of the patient is good, then we'll see what are the complications the patient is having. If the patient is having biliary obstruction, or if the patient is having a gastric outlet obstruction also. And if the cancer is potentially resectable, then they will go. Then we will have to go ahead with the surgical exploration. Or if the surgical, if the cancer is not potentially resectable, then we will have to treat only the biliary or the gastric outlet obstruction. Let's say if the carcinoma is surgical exploration is possible, then we'll go ahead with the resection. Or if there are already metastases and where the complete resection is not possible, we will see if there is any biliary obstruction or if there is any impending gastric outlet obstruction. If the answer is yes, then the preferred surgery would be a double loop bypass. And if there are, if at that point of time, if there are no clinical or laboratory evidence of both of this, if there is only biliary obstruction, then biliary bypass is done. Or if there is gastric outlet obstruction, and then a gastrojejunostomy can be performed. And let's say if the cancer is not resectable, then everything depends on the prognosis of the patient and the estimated survival of the patient. Let's say if the estimated survival of the patient is more than 4 months, then the better option would be the endoscopic palliation with self-expanding metallic stents, or we can even consider gastrojejunostomy. And let's say if the estimated survival of the patient is less than 2 months, then endoscopic palliation with the plastic stent will be preferred. Or if there is any gastric outlet obstruction, then PEG option can be preferred. Let's say if there is only biliary obstruction and the estimated survival is more than 4 months, then the preferred option would be endoscopic palliation with self-expanding metallic stents. And if the estimated survival is less than 4 months, then plastic stents can be used. Coming to the first option for the palliation of cholestatic jaundice, that is the surgical bypass. Here we can see an image which depicts the Roux-en-Y hepaticojejunostomy for the gastric outlet obstruction. But usually surgical bypass options, they are not usually warranted because of the poor expected survival, and it is also associated with the greater morbidity and considering the poor general condition of the patients. Next option, that is the PTBD, percutaneous transhepatic biliary drainage. It is an image-guided procedure which can be performed under fluoroscopy or combined ultrasound or fluoroscopy guidance. Its indication are varied, including both obstructive as well as non-obstructive jaundice. Coming to the main indication, it is the cholangitis, or maybe due to the pain elevation, or to decrease the intractable pruritus, or to decrease the serum bilirubin before the initiation of chemotherapy. Coming to the contraindications of the PTBD, the absolute contraindications are like the uncorrectable bleeding diastasis, and the relative contraindications are the INR more than 1.5 platelets if the platelet count is less than 50,000, if it is associated with ascites, or if there are any multiple hepatics. These conditions like bleeding diastasis and INR of 1.5, it can be commonly found in malignancies associated with the biliary tree because of the impaired absorption of the fat-soluble vitamin like the vitamin K. And coming to the post-procedure management, it forms a very important part of the PT after the PTBD. Patient has to be just kept in hospital for observation and to monitor the vital signs. And the analgesia for the post-procedural pain is also a very important thing. And it has to be done under antibiotics coverage for a week. If the patient is able to tolerate the internal drainage, then we can discharge the patient, or else we'll have to maintain the external catheter and we'll have to maintain oral hydration and to avoid the fluid loss. Most of the patients in our hospital who face this problem with malignant biliary tree obstruction, They are mostly referred to as post this procedure for the post-procedural pain. So many patients present our OPD with the PTBD in situ and the pain at the procedure site. So as it is a post-procedural pain, it is an inflammational pain, and NSAIDs are preferred unless there are any other contraindications. And coming to the complications of the PTBD, there can be minor complications like pain and the pericatheter leak. And there are even major complications like cholangitis, or it can lead to sepsis. It can even cause biliary peritonitis, pancreatitis. And there are rare complications due to these interventions like pleural effusion or the pneumothorax. And the next procedure, which is the ERCP, endoscopic retrograde cholangiopancreatography. The ERCP with the placement of plastic stent is another effective method of biliary drainage. And mostly this procedure is preferred if the obstruction level is beyond the level of hilum. And coming to the contraindications, as it is an endoscopic procedure, if there are any pharyngeal or esophageal obstruction or active coagulopathy, this is contraindicated. And the relative contraindications include acute pancreatitis, severe cardiopulmonary disease, or if there is any distortion of ampullary anatomy, or if there is any duodenal stenosis. In general, the replaceable plastic stents, they are used for those with a longer life expectancy based on the results of a RCT. Plastic stents, they need to be replaced every 3 months for best results and to minimize cholangitis. This requires repeated endoscopic procedures. For this, the patient's general condition, it also has to be in a good condition. And the metal expandable stents, they remain patent for a longer time and they are associated with less cholangitis, but they cannot be readily removed. And when the tumor advances, it may lead to the complete stent occlusion. There was a randomized trial of surgical bypass versus the endoscopic intubation, and it favored that endoscopic procedures, they were better than the surgical bypass. And let's say the unresectability, it is determined only at the time of an open exploration. A palliative bypass for biliary decompression and jejunal bypass may be performed. A surgical bypass to the common bile duct does involve the morbidity associated with laparotomy and bowel anastomosis. A laparoscopic bypass of the distal bile duct obstruction can be performed usually with the cholecystogeganostomy. This will be unsuccessful if the common bile duct at the level of cystic duct is involved with the tumor. And what are the recommendations for the biliary drainage in the palliative care? If the obstruction is at the proximal level or the hilar involvement, then PTBD or the ERCP is preferred. If the obstruction is distal to the hilum, then ERCP is preferred. And if it is an inoperable case with shorter life expectancy, let's say 6 to 12 months, then metallic biliary stenting is preferred. And coming to what are the other issues which can be seen in the patients of malignant biliary tree obstruction. First, and one of the major important complication is the hepatic encephalopathy. The hepatic encephalopathy, it is a spectrum of neuropsychiatric abnormalities in patients with liver dysfunction after exclusion of the brain diseases. And it is characterized by personality changes, intellectual impairment, and decreased level of consciousness. It is mainly due to the diversion of portal blood into the systemic circulation through the portosystemic collateral vessels, or it may be also due to the creation of the portosystemic shunts which are created during the surgery. Here in this image, we can see the pathophysiology of the hepatic encephalopathy. Whatever the dietary ammonia or the ammonia which is formed by the colonic flora, or the muscle or the muscle or after the muscle breakdown, whatever the ammonia is formed in the intestine, it is taken up by the liver and it is excreted from the liver and also through the kidney. But when there is excess amounts of ammonia are accumulated in the GIT, it can easily cross the blood-brain barrier, and it helps in the conversion of glutamate to glutamine in the astrocytes. And when there is excess production of glutamate to glutamine in the astrocytes, it leads to the free radical damage and also increases the permeability of the astrocytes, causing the astrocyte edema and also the brain edema. The clinical features Coming to the clinical features, first feature might be the asterixis, but it is not very specific to hepatic encephalopathy. It is also seen in metabolic encephalopathy, uremic encephalopathy, or also it is seen in barbiturate toxicity. And the other clinical feature can be fetor hepaticus, which is due to the formation of the mercaptans. And there can be also a lower extremity weakness, and patient might be complaining difficulty in walking, and there might be hyperreflexia, which are usually characterized under hepatic myelopathy. And patient can also present with extrapyramidal symptoms. And this hepatic encephalopathy, there is a Westhaven criteria for grading the hepatic encephalopathy. There it is graded into grade 1, 2, 3, 4. Grade 1 is called, it comes under covert, where there is inattention and there is altered sleep pattern, there is decreased attention span, patient will be anxious. And grade 2, 3, and 4, they comes under overt, wherein grade 2 asterixis can be seen. The patient will be having personality changes. The patient will be having hypoactive deep tendon reflexes. In grade 3, patient will be almost in semi-stupor, but he will be responsive to stimulus. There will be time and place disorientation. Asterixis and asterixis will also be present, and deep tendon reflex, they will be hyperactive. Grade 4 is the coma. In this image, we can see the flapping tremors or the asterixis. And there's another scale that is called the chest scale for the evaluation of hepatic encephalopathy. Here it is a total score of 9, where there are 9 questions, and we'll have to score if by yes or no. But the disadvantage of this scale is this scale does not use asterixis anywhere. And then coming to the treatment of hepatic encephalopathy. One of the main treatment of hepatic encephalopathy is the lactulose. Lactulose, which after intake of the lactulose in the GIT, it converts into lactic acid and the acetic acid, and it helps in the acidification of the gut lumen. When there are excess production of H+ ions in the gut lumen, it helps in the conversion of NH3 to NH4+, which is relatively low absorbable. And it also, as there is increase H+ ions, it decreases the fecal pH, and it also increases the fecal nitrogen excretion. And it also helps as a cathartic, and as it decreases the colonic bacterial load. And the effective dosing must be as such the patient is passing 2 to 4 loose stools per day. And next option is to use the rifaximin. It is an antibiotic which is used for secondary prevention after establishing the diagnosis. It decreases the intestinal bacterial load, and it also decreases the activity of intestinal glutaminase. Here we can see it also decreases the bacterial translocation. It downregulates the immune response, and the preferred dose is 550 milligrams twice a day. It also helps in decreasing the hepatic inflammation, and also decreases the pro-inflammatory cytokine release, also decreases the systemic inflammation, and also endotoxemia. And coming to the next most common symptom is the pain. 75% patients will present with abdominal and or associated with back pain, and 80% of the patients with advanced pancreatic cancer, they will experience severe pain prior to death. It is commonly associated with the malignant invasion of the celiac plexus. Although many patients are treated with oral and transdermal analgesics, there is evidence that patients who undergo early regional neurolysis of the celiac plexus, they experience improved quality of life. In 2011, there was a Cochrane meta-analysis of 6 RCTs, and they found that the celiac plexus block, it results in a significant decrease in pain at 4 and 8 weeks post-procedure. Additionally, there was a durable decrease in overall opioid consumption and associated adverse effects. And there are 4 ways to perform a celiac block, that is intraoperatively, percutaneously, endoscopically, or thoracoscopically. The intraoperative celiac block is performed by injecting ethanol or a local anesthetic to either side of the aorta at the level of celiac axis. In a double-blind RCT, the intraoperative celiac block, it produces a statistically significant decrease in pain and the opioid consumption when compared with the saline control. In a meta-analysis from 2009, patients undergoing endoscopic ultrasound-guided celiac plexus block, they had 85% response rate compared, measured by improvement in the pain score. Coming to the side effects associated with the celiac plexus block, it can result in urinary retention, back pain, and diarrhea seen in about 38 to 40% of the patients. It is due to the unopposed parasympathetic tone. Patients can also experience transient orthostatic hypotension secondary to the vasodilation, which can almost last for a week. The more serious but rare complications, they include permanent paraplegia or the transient paraplegia, abdominal aortic dissection, or retroperitoneal hemorrhage. In this image, we can see the location of the celiac plexus, which are located on the either side of the abdominal aorta. And here is an image where celiac plexus block was performed at our center. And coming to the pruritus, it is a major symptom of the obstructive jaundice. Pruritus may occur with any type of liver disease, but it is primarily associated with acute or chronic cholestasis. It is estimated that it occurs in 20 to 50% of the jaundice patients. The intensity of pruritus, it varies from mild to severe. It can be persistent, intermittent, and it can be even localized or even localized to only specific parts of the body, or it can be even generalized. Commonly, the pruritus due to cholestatic jaundice is found in soles of the feet and palms of the hands. Coming to the pathogenesis of the cholestatic pruritus, it is a very complex procedure. It is a very complex and multifactorial. As of now, there are no solid evidences, but whatever the evidences and the studies have been done, they show that it is due to the dermal itch receptor stimulation caused by the bile acids which accumulated and the lysophosphatic acid, and also endogenous opioids and progesterone derivatives. And not all jaundice patients, they suffer from the pruritus, but all these patients with pruritus, they have elevated level of serum autotaxin, the enzyme that converts lysophosphatidyl to lysophosphatic acid. And interestingly, the rifampicin, it downregulates the serum autotaxin transcription, and this may contribute to its efficacy in relieving the cholestatic itch. And there is also a central mechanism which is associated with altered neurotransmission in the brain. It has been seen that the opioids and the serotonin antagonists, they reduce scratching activity in cholestatic pruritus. And it is finally, there is an evidence that skin bilirubin is correlated with itch severity, and that bilirubin may bind to activate a mass-related G protein coupled receptor and itch encoding sensory neurons. And coming to the treatment for this pruritus, this table is from the Scottish Palliative Care Guidelines, where they have mentioned the treatment as first line, second line, third line. Here, the first line treatments available for the cholestatic pruritus is the rifampicin at a dose of 300 to 600 milligrams once daily. And the next option is the sertraline, which can be used up to the maximum dose of 50 to 100 mg once daily. And another option is cholestyramine, which can be used up to 4 gram up to 4 times daily. That is the combined dose of 16 gram per day. Cholestyramine acid, it acts as a binding agent to the bile and helps in the excretion of the bile which is accumulated in the GI tract. And whenever we see a patient with pruritus in a cholestatic jaundice, the first advice must be to trim the patient's nails. By doing this, we will stop the cycle of itch, scratch, and itch cycle, and this also helps in reducing the itching. And we should also take care of the general measures like the moisturizing the skin and also maintaining the local hygiene, so as to prevent other infections and to prevent other itch, scratch, and itch cycle. And coming to the other complications which can be seen in the patients with malignant biliary tree obstruction are the gastric outlet obstruction. As the as the most common cancers causing malignant biliary tree obstruction are the CA, pancreas, and the gallbladder. Due to the close proximity to the GI tract, they can also cause gastric outlet obstruction. So it is found in 10 to 20% of CA pancreas and 50 to 20% in the patients of CA gallbladder. Laparoscopic gastrojejunostomy is preferred than the open gastrojejunostomy, but prophylactic gastrojejunostomy is not recommended, and instead it should be all these procedures they have to be decided on case-to-case basis. With advance in the endoscopic techniques, the management of obstruction can be performed endoscopically with the placement of self-expanding stents, and the success rate is also good while using these stents, like 92 to 100% of the cases. And the patient can start oral intake in almost like 24 hours. And another problem found are the thromboembolism. And the pancreatic cancer patients, they have the highest incidence of DVT or the pulmonary embolism, with rates ranging from 17 to 57%. Although the presence of thromboembolic disease is associated with a worse prognosis, treatment can improve the longevity and the symptomatology. Treatment for all venous thromboembolism include treatment with the low molecular weight heparin, unfractioned heparin, or oral anticoagulation, depending on the case-to-case basis. Till now, we saw all the complications what the patients can have and what are the treatment options available. But finally, the involvement of patients, families, and physicians and advocacy groups throughout the care process, beginning at the time of diagnosis, and utilizing the palliative care triangle to clarify a patient's and family goals, it allows for the better interpretation of potential outcomes in ways that are meaningful to all the stakeholders. This allows patients and their physicians to choose the right treatment at the right time, at the right setting. Here in this palliative triangle, we can see what are the patient concerns. The main patient's concerns will be the pain and symptom management, and patients should also feel that they should have the ability to participate in desired activities. They feel like they should have the control autonomy, and they also want to avoid suffering and also the prolonged death. The family, they always think of education and management of the expectations, bereavement, and how to support the patient. And as palliative medicine physicians, we should think about the pain and symptom management, minimizing the risks and unneeded interventions, trust and communication, and we should also concentrate on avoiding suffering and not prolonging the death. And all the procedures that we discussed till now, like the PTBD or the ERCP, it all boils down. It also has a financial component to it. Usually at our center, the ERCP costs somewhere around 60 to 80,000, and a PTBD costs somewhere, PTBD with an self-expanding metallic stent, the cost comes down somewhere around 1 to 1.5 lakhs. So it's very essential to have a very good discussion with the patients and the caregivers about all the help, all the indications for this treatment, and all the complications that are associated with this treatment, and depending on the overall expected survival of the patient, and even the expected survival of the patients, and the prognostication has to be done so that they can take a very informed decision. Here, all the malignancies with the biliary tree obstruction, we are dealing with an overall survival in metastatic CA pancreas of about 3 to 6 months, and the median survival in metastatic CA gallbladder is 4 to 5 months. So whenever the time is so limited, it is necessary that we consider the factor of time toxicity in the cancer treatment. Here in this slide, we can see two hypothetical options, that is option A and option B, where the patient is offered a chemotherapy. So the patient will be having frequent clinic visits, and the patient will have to bear the chemotherapy toxicity and will have to undergo hospitalization due to that, and he might even require rehabilitation. And the overall survival, which can be improved without a non-cancer treatment, might be 30 days. But whatever the extra days that he is getting, he might be spending all these days in the hospital visits and also in the treatment. But let's say if the patient, when there is no cancer-directed treatment available for the patient, the overall survival will be just 120 days. But out of those days, there will be very short hospitalization for symptom control. And most of the days, patient will be comfortably spending at home. So we need to even give a fair idea for the patients about all these issues. And coming to the last part, that is the end of life care and the role of hospice. Owing to the aggressive nature and particularly poor prognosis which is associated with these malignancies, they can leave patients and families feeling blindsided when they are suddenly faced with the end of life decisions. Therefore, it is very crucial to clarify the patients and the families' goals from the onset and address the misconceptions they have about the various treatment options and survival. These conversations, they can be most time consuming and they are also difficult portions of the patient care. But establishing clear goals early, it avoids the unnecessary complications, cost, conflicts, and also especially as goals and attitudes, they evolve with the changing prognosis. When discussing potential interventions, it is critical to discuss not only prognosis, but also the potential benefits and arms of each and every procedure. But unfortunately, there is very little information available on the outcomes such as the quality of life or the time spent in the hospital and other outcomes that may be important to the patients, it thereby limiting the physician's ability to help patients make these informed decisions. And despite the fact that enrollment in hospice care has been associated with lower Medicare costs and improved quality of life, including the improved pain, less fatigue, and lower depression and anxiety rate, it is a grossly underutilized as of now. So there must be early introduction of the hospice care, and it helps to normalize the concept to the patients and families and give them ample time to clarify any misconceptions. Moreover, it is possible that a paradigm shift may occur when the receipt of hospice care may no longer mean the patient have to forego potentially curative therapies. And here I have mentioned the references which I have used for the which I have used to make this presentation. Thank you.
Thank you, Varun. As already presented by Dr. Varun very well, in a very symptomatic manner, what are the common symptoms and what are the interventions which we ideally offer to this group of patients, and why we have to offer such interventions to this group of patients was very well presented. And one thing we have to always understand, and I always tell in my teachings to my students, is that prognostication is very, very important in palliative care medicine, because every intervention, every consultation, or I can say whatever family meetings we do, everything is based on the prognostication of this patient. So if we know the prognostication is less than 3 months or more than 6 months, based on that we try to divulge I can say the information needed to the patient. So we can't be talking about the last days of life when the patient is having a prognostication of 6 months, because that is not easily accepted by the relatives as well as the patient, because whatever patients we encounter, they always are of the hope that they get some form of treatment. So that's why prognostication plays a major role. And one more practical point, if you might have listened to this talk, was the commonest symptom is pruritus. So most of these patients come with pruritus, and a very practical point which Dr. Varun has told is that advising the patient to cut his nails, right? Because if the big nails, they scratch it, so that's the vicious cycle of itching, scratching, and all those things, and that again becomes a vicious cycle, and there will be more pruritus in this group of patients. So that's why we always advise our patients to cut the nails. That's another point which I wanted to highlight again. This thing. So coming to the treatment options, PTBD and ERCP, these are the only two options which are currently available and the best options. But again, they are also based on the prognostication or the life expectancy. And another major aspect is that whether on the bilirubin level, because if there are no other comorbid conditions in this group of patients, and the bilirubin is only the limiting factor for not giving them chemotherapy, then we advise them to undergo PTBD or an ERCP. And once the bilirubin level comes down, and that cutoff mark is usually 2, when the medical oncologist usually gives a chemotherapy to this group of patients. So either is that group, or if there is a very intractable pruritus, which is not amendable or treatable by the available pharmacological and non-pharmacological options, then we offer PTBD or ERCP based on the patient's general condition or ECOG status, as well as the financial condition of these patients. So very nicely presented, Dr. Varun, and we are open for taking the questions. One more thing I just wanted to put forward into the platform of our experts is that we had just one query. When we see these patients and when the patients are declared best supportive care, and when we send the patients home and with a life expectancy of less than 3 months, and they already had a PTBD stent. So we always have a question whether we have to take the PTBD stent out and send them, or we send them with the PTBD.
Whom you are asking?
Yes, I am asking the experts, madam. Experts' opinion.
So according to me, if patient is having PTBT and life expectancy is 3 months, and PTBT is helping in the relieving jaundice and symptoms, it can be continued, provided it is properly fixed and it is not troubling patient a lot. Otherwise, internalization is also an option that we can ask radiologist, interventional radiologist, to do internalization of PTBT, so that there will be no drain outside. And this is the thing which troubles a lot to the patient, that they are with the drain and bag all the time. And last 3 months of life, I don't think that anybody will like to have this. So this is what. But if it is not helping, it is not relieving jaundice, definitely we have to remove. But if symptoms are already, if it is there, you are asking. However, it is very important to decide based on the patient condition our goals of care. Because what I have seen, and this was one of our thesis topic for 2 radiology students, and I was his co-guide, that how much we are helping to the patient in last 6 months of life by providing PTBT. And what they have seen in both the groups, there is hardly any quality of life improvement in PTBT group. So especially in patients where prognosis is very poor and there is no treatment option possible. So this is very important, that we should have a clear idea, and assessing your patient is very important, whether we are doing PTBT or ERCP. It doesn't make it, whatever you do, even if patient is affording, it is not necessary to go unnecessary intervention. But definitely, if it is being done, that there are therapy possible, and they are just waiting that bilirubin should come down, and by draining procedure, and they will give the therapy, chemotherapy. They want to give chemotherapy, and this is going to help patient. Definitely we should do. So this is again a very difficult decision, but it is not very impossible decision, and very, very difficult till you know your patient very well. If you know your patient, you can decide very well about all these aspects. Dr. Jennifer, you want to add anything?
Thank you,
Okay.
ma'am. Thank you, Varun, for that excellent presentation. Yes, so I think what Dr. Sushma mentioned is very important, because this is a patients who present with obstructive jaundice and malignancies involving the hepatobiliary are generally those with poor prognosis. So definitely the disease-related factors and patient-related factors have to be considered, and this palliative intervention of relieving obstructive jaundice has to be really an informed decision, because not just the cost, but also the complications and the risks associated with this. Meaning, I've also come across many patients who go through this, but finally succumb to the complications of like infection, blockage, or deteriorating general condition, and finally do not end up having oncological treatment. So choosing the right patient is extremely important. The other thing I would like to emphasize, which Dr. Varun also mentioned, is this choosing patients for the celiac plexus block early on, especially if we think pain is a big problem, and many of them don't end up with oncological treatment, so symptom relief becomes an issue. So choosing and giving celiac plexus block at the right time if pain is an issue is important. In those with whom celiac plexus block is not possible because of distorted plexus region nodes, then sympathetic lysis is also can also be considered. Thank
This
you.
is absolutely true, Dr. Jennifer, that celiac plexus block and splanchnic plexus block.
Yes, splanchnic plexus block. Sorry, yes.
Splanchnic plexus block. These are the two blocks which are so important in these group of patients. It's so important. Only thing we should, because they will not need, many times they will not need morphine, and otherwise morphine in obstructive jaundice patient, we know that it metabolizes through liver, so it becomes a vicious cycle and patient really become really sedated. So we can avoid opioids. However, we can titrate with fentanyl, but giving block is a very good option in these patients. So this thesis is also going on that in CA gallbladder and CA pancreas patients with the advanced malignancy early. This already my student has done, and one more radiology student is doing now with this splanchnic now block. So I think with this kind of evidence, I think we will be able to give some justification that whatever we are, it's already evidence based otherwise. But from India, I think we will be able to give some figure and some evidence from India side also. So anyone or Raghu, you want to summarize if there are no questions?
There was one question whether we want to give, based on the life expectancy in the chat box, whether to give a celiac plexus block or not. So what I feel is that it's not actually the life expectancy, because there are other things which matter a lot when we are performing these interventions. And the most important thing is that because most of the times either it is a CA pancreas or a CA gallbladder or with an HCC, there is a lot of issues with the coagulation. So there's a lot of coagulopathy in this group of patients. So that is the factor which actually prevents us to do interventions in this group of patients. So even if the patient's life expectancy is less than 3 months, but is well controlled with morphine, there is no need of an intervention. But if you think that the patient's morphine doses are too high, way too high, maybe around more than 300 milligrams per day and all, in such group of patients, yes, you can perform a celiac plexus irrespective of his life expectancy, provided there is no coagulopathy. But if you ask me,
Raghu, for this, I want to add that whether life expectancy is even 1 month, and you see that patient is in severe pain, and celiac excess is free, we must give block, because this will reduce the medication.
Yeah, so I'm not denying that fact, but I'm saying that selection is the utmost importance.
Yes,
that is what we give a lot of weightage to, that selection rather than indication. All right. So thank you very much. Thank you, everyone. Thank you, madam, to giving us a wonderful opportunity to present a very, very important topic in palliative medicine. Thank you, Dr. Joita, for introducing Varun as myself as me. And thank you, everyone, for patiently hearing us for almost 45 minutes to 1 hour. And thank you once again, IAPC.
One question, Raghu, what is the red flag or contraindication of celiac plexus block? You want to give answer, or I should give?
No, that's what I said. Coagulopathy is the biggest red flag for us. That's what I'm telling. So, and second, it's a relative contraindication is the tumor invasion. So if there is a lot of tumor invasion, if there are no planes, we can go for a splanchnic neurolysis. That's a easiest option. But for the celiac axis, if you ask me, only coagulopathy is the biggest contraindication, or I will not say it is a red flag, but it is the biggest contraindication. It's absolute contraindication.
So Raghu, I think absolute contraindication, I have seen 50% of patients, they refuse at the end of life. They say, I don't want any intervention. So patient refusal is absolute contraindication. then coagulopathy, and then definitely if celiac axis is matted with the lymph nodes, I think we just cannot give, and we have an option of giving splenectomy block. But there are patients who wants to have intervention and they want that medication should be reduced as much as possible, and we can reduce by giving these medications. So thank you, Raghu and Varun. It was a fantastic presentation. Thank you very much.
Thank you, everyone.
Very good. See you everyone next week, Monday morning before 6:30. Thank you, Archana, and thank you, Nisha. And thank you everyone for joining.